Good morning, everyone. I'm Dr. Scott. I'm from India. I'm really very honored and excited to part in this Budapest Proctology European Congress. This is the first time I come to this beautiful place, and also my heartfelt thanks goes to the team Proctology, especially Dr. for giving me this opportunity to share my insights and thoughts on this unique topic. We all know there's a huge hue and cry on this fistula management. Before my speakers, Dr. David and many esteemed speakers who have got wide knowledge on this fistula, I do not know how I'm going to move on. Let me see. 180 years old Madras Medical College from Chennai. Also, I had my fellowship from the Royal College of Surgeons in India. I have got 25 years of experience in the field of proctology, and I've been doing, 25 years of experience in the field of general surgery, and I've been doing dedicated proctology for the past 7 years. So, as we all know, we are all general surgeons. So, India is a big country of 1.5 billion population. India begins from my hometown. My house is situated at the lowermost part of India. That place is Nagarkoil. So here I share my experiences, and I do 400 to 450 cases per proctology cases per year, and I have got a 15-bedded hospital, as well as I'm a teaching faculty in one of the reputed general surgical institutions, that is Dr. J. Hospital. Well, here I share a patient. He's a 35-year-old gentleman from Australia. He's a Sri Lankan refugee who's been there for the past 8 years. And he had multiple surgeries that he placed a seat on. Someday he came to know about me and he traveled to my place. Sorry. Go back. There you go. So when I saw that, he had multiple external openings. Back. So he had there's a multiple external opening, and it's a Y-shaped tract. One external opening at the 11 o'clock and one opening at the 6 o'clock. And they join together, and the internal opening is at 6 o'clock. So it's a high transsphincteric fistula, long tract. So what I do is, we do generally sphincter cutting procedures. I'm totally against from this august audience who always prefer to do a sphincter preserving procedures. What we do is, I totally de-explore the ischio rectal fossa and try to identify the tract. You can see that Y-shaped tract. Whatever the length of the tract, I try to dissect it out, and so that, and I find out where exactly it penetrates the external sphincter. I do cut the external sphincters, the subcutaneous part, superficial part, and deep part. And I do primary sphincter repair. So for this gentleman, the first one is the immediate post-operative period, and this came after 2 weeks, and wound completely healed in 46 days. He stayed there in my place for a period of 1.5 months until the wound gets healed. And we rarely see incontinence, whether it's a flatus continence or a liquid or a stool continence. Another gentleman has been operated in one of the most reputed hospital in India, being operated 2 times by a surgical gastroenterologist. You can see the external opening at the 7 o'clock position, almost 15 centimeters away from the anal verge. And there were dangling cetons. MRI done, it turned to be a suprasphincteric fistula. I don't have the MRI. So this gentleman, similarly, I did a total dissection of the tract. We do total fistulectomy, sphincterotomy, and primary sphincter repair, and thorough curettage of the tract. Here you can see, prior to the cutting of the deep part, I have placed the curettes instrument. Here, after cutting the deep part, I have kept the probe. And the wound was a little bigger, so I did a closure. There has been limited closure, and the wound completely healed in over a period of 2 months. This patient was almost not going because of the multiple surgeries. This is another gentleman is a driver who's been operated 4 times. You can see multiple scars in the right side, and whenever he gets some pain and swelling, he goes to a local surgeon, he does IND, and this is the way he came to me. When I examined, I found a bulge in the anal canal in the mucosal aspect from 6 to 9 o'clock. There were no tenderness in the perianal area. So it's turned to be an intersphincteric abscess. So what I did is I did a simple de-roofing of the opening of the intersphincteric space. That is called as TROPIS. That is transnanal opening of the intersphincteric space. Once the space is totally opened, it was curated and discharge is sent for tuberculosis estimation. Tuberculosis is a national disease in India, and this is another patient. Even I submitted my study in one of the index journal. My TB incidence is almost 10%. So this is one of the oldest study. So this is another gentleman, a 60-year-old retired college professor who came to me with an on and off swelling in the perineum. He was moving from pole to post for the past 8 years. He had a crack treatment as well, and also he had a discharge from the urethra. So he had a big file folder with multiple tests done, like ascending ureterogram, MRI, whatnot, and they said it's a very complex fistula, nothing can be done. So it's obvious it's communication with the membranous part of the urethra. So it's a communication with the urethra and the anal canal. So in concurrent with the urologist, I did a SPC first. Once the diversion done, after 3 months we did a fistulotomy, total exploration, de-roofed the perineum, and we did a thorough curettage. And since during surgery, we did a Foley's catheterization as well. So we can plan, we can palpate the urethra so that you won't injure further. So the tract completely healed, and then we did a check ureterogram, and that also turned to be little urethral stenosis, and the patient is totally disease-free. The fistula part is closed, but being advised by the urologist for a serial urethral dilatation. This is another gentleman.
I'm sorry, we have to go.
Malignant spinal cell tumor. To my surprise, I haven't seen a malignancy in the fistulous tract. I called the pathologist. He also agreed. We haven't seen, and they had a multiple session with senior pathologist, and so we referred the patient to a local oncology center where they had a multidisciplinary approach, and they had treatment of a non-Hodgkin's lymphoma with a chop agent. Thank you, gentlemen and ladies, for your patience.